it is really my pleasure to be here with everybody today. I want to thank everybody for joining us at this event that's focused on ending pediatric AIDS. First, I need to start with some apologies. My boss, Winnie Biangiba, is unable to make it, so I will attempt to combine my introductory remarks with also conveying her remarks for the beginning of this meeting. First, I must say we have a very full agenda and an incredible lineup of guests focused on ending AIDS. So I'm going to try to be fairly brief, even covering for the two of us. You know, first, just to reflect, this is such an important week. The fourth high-level meeting on ending HIV/AIDS is in play, and that's why we're meeting here today. Just want to congratulate all of the member states and civil society. The General Assembly did adopt the political declaration on HIV and AIDS just about an hour ago. So huge amount of work already done, and congratulations to everyone who was part of that process. But we are here today because HIV really does remain a major public health threat in children and adolescents. First, I'll talk a little bit about the numbers, perhaps, and then I'll talk a little bit about the people and the meaning of that and the political commitment we need. Just to note that this is the 40th anniversary, of course, this week of the first description of AIDS. And that has so much meaning for so many of us. But I must say, children have always played a very interesting place in the HIV response. At times, they've been the positive focus of political attention, but in realities, they've often been the least completely addressed and served. And when we look at the numbers, we really see that combination of both progress and also inequalities about how kids are left behind. You know, progress globally, the number of AIDS-related deaths among children aged 0 to 9 has fallen by more than a half, nearly 60% since 2010. And among adolescents 10 to 19 by about 36% because of expanded treatment services. Children living with HIV are now more likely to survive into adolescent and adulthood. And globally, you know, 84% of pregnant women living with HIV have accessed HIV treatment, and 95% of pregnant women in Eastern and Southern Africa. So that tells us a lot of what can be achieved. But then the reality is a bit stark when we compare it to where we want to be and where we should be. Globally, only 53% of kids are on HIV treatment. That is vastly below treatment coverage for any other population. The rate of treatment coverage for all adults is 74%. The rate of treatment coverage for pregnant women is 84%. So we clearly have a big gap here. About half of those missing children, there's about 850,000 children, that means over the last 14 we've missed. They're children living with HIV who haven't been diagnosed and aren't on treatment. And about 2/3 of those are aged 5 years old or older, meaning they're not going to be found just by business as usual, just by tapping into the routine infant or immunization services. But also, we still haven't fully made sure we don't miss more kids. In 2019, about 60% of infants born to pregnant women living with HIV received a test for HIV by their 2nd month of age. So that's only 60%. We want it to be 100%. So we're still missing kids that could and should be diagnosed early and really benefiting from lifelong therapy. And then finally, about 300,000 adolescent girls and young women became HIV positive in 2019, almost 3 times what we had hoped for 2020. So clearly, we have a problem. Pregnant and breastfeeding women are missing out on the critical HIV testing, treatment, prevention services that can avoid vertical transmission of HIV, hepatitis B, and syphilis during pregnancy, birth, or breastfeeding, and to preserve their health. Sadly, even if women do reach these services, they're not always provided with the support needed to remain in care and can be lost to follow-up during pregnancy or breastfeeding or thereafter. And these challenges we're seeing don't arise from a lack of effective tools, but through a lack of political commitment and leadership to prioritize the needs. We know that there have been incredible investments to increase the speed and accuracy of testing HIV-exposed infants with the point of care technologies, allowing immediate treatment initiation. We now have child-friendly generic formulations of optimized HIV treatment regimens, and these have been approved in record time, thanks to the collaboration of many of the folks who are on this call today. But these innovations aren't being taken to scale, and the quality needed to reach all mothers and children due to a lack of advocacy, funding, high-level political commitment, leadership, and accountability at all levels. To give our future generations the best start in life, 3 things must happen, and they've got to happen quickly. First, we need bold commitments from political, religious, and traditional leaders, especially in the highest burden countries, to recommit to eliminating vertical transmission of HIV, hepatitis B, syphilis, and ending pediatric AIDS by 2030. Furthermore, and most importantly, these leaders need to ensure that their commitments are acted upon. Second, we need to develop a strong country, regional, and global accountability framework that will drive, support, and monitor country progress towards achieving these ambitious targets that are set in this political declaration, and that provide adequate technical and financial resources. And finally, in this era where we fear shrinking funding for the AIDS response, we must be both creative and committed. We must look for earmarked funding for children. We must find synergies in the COVID funding that can improve the finding of missing children and family services. And we need to strengthen laboratories to increase access to point-of-care early infant diagnosis and viral load testing. And furthermore, we need to continue to strengthen health information systems that can provide us with granular data that we need, not only to deliver precision public health action that works for children, adolescents, and women, but to continually reassess, re-examine, and identify who's being left behind, who are the kids being missed, the parents being missed, and how do we remedy that? So again, I want to thank everybody for coming here today. And I want to go ahead and hand off to our panelists. So our first speaker, we are delighted to have the Acting Global AIDS Coordinator, Anjali Atrikar, with us. So Anjali, over to you.
Great, thank you very much, Shannon, and thanks to everyone for joining today on this really important and critically essential panel. I think Winnie said it so powerfully in the opening plenary earlier today when she said, inequalities kill. And children are among those who are bearing the burden. You shared the data so clearly, Shannon, just earlier. Together with our partners, the United States remains deeply committed to ending the HIV epidemic, including ending inequalities for children through the President's Emergency Plan for AIDS Relief, or PEPFAR. Preventing mother-to-child transmission, finding undiagnosed children living with HIV, and ensuring all children and adolescents living with HIV receive optimal care and treatment have been key tenets for PEPFAR since its inception in 2003. But as we noted earlier today, during the political declaration deliberations, outdated and ineffective interventions must be dropped and replaced with those that effectively reach key populations, adolescent groups, and adolescent girls and young women, and children. These populations, these individuals remain at risk for HIV and have clear unmet needs. We must meet those needs together. As we see stagnant progress in HIV prevention and treatment for children and pregnant women, PEPFAR has and will continue to intensify our efforts to address these inequalities. We have the tools and strategies necessary together to prevent HIV transmission and to identify and treat children living with HIV, but programs have struggled with fully scaling these strategies. Renewed visibility, recommitment, and policies on pediatric HIV/AIDS are urgently needed from national and community levels to close the gap for pregnant women and children. Given the urgent need to redouble global efforts to deliver an AIDS-free future for children, we are rapidly deploying better DTG-based ARV regimens for children, expanding early infant diagnosis, viral load point-of-care testing, relying on partnerships between orphans and vulnerable children and clinical partners to support the pediatric care continuum, expanding multi-month dispensing, and differentiated service delivery models to improve family-centered care. Specifically, in the setting of COVID-19, PEPFAR programs have made quick program adaptations to ensure children and women are not left behind. While we're deeply distressed by the global pediatric HIV shortfalls, we're also encouraged by the fact that we have the tools. We need the political will, and we need to make this change quickly. So let this be a call to action for all of us attending this event to always challenge complacency and to work tirelessly to close the gap. We're incredibly grateful to our co-sponsors and the speakers on the panel today for realizing this powerful and impactful event, and we're honored to partner with all of you on this journey to ending pediatric AIDS by 2030. Thanks, Shannon.
Thanks, Anjali. And just let me say, we're grateful for you. We're grateful for PEPFAR's continued commitment to this issue, your investments at country level and in partnerships, including the Vatican partnership and faith-based partnerships who've been instrumental in really helping us finally accelerate this development of optimization for pediatric formulation. So thank you very much. So we now have 3 videos from speakers from around the world. First, we'll hear from Dr. Jean-Jacques Mbugani Mbanda, the Minister of Health from the Democratic Republic of Congo. Then from Henrietta Fore, Executive Director of UNICEF. And finally, from Dr. Mashidiso Moedi of WHO Afro. So over to our tech for getting our videos going.
Madame la Directrice Exécutive de l'ONU-SIDA, Madame la Directrice Générale de l'UNICEF, Madame la Directrice Régionale de l'OMS, Madame la Coordinatrice du PEPFAR, Monsieur le Président de la Fondation Elisabeth Glaser, Madame la Directrice de l'ICAP, Mesdames et Messieurs, à vos titres et qualités respectifs. Je suis heureux de me joindre à vous pour cette session spéciale axée sur la prise en charge pédiatrique du VIH. Tout en félicitant les organisateurs de cette rencontre, je voudrais sincèrement remercier la directrice exécutive de l'ONU-SIDA, Madame Wivini Dianima, pour son invitation. Je saisis cette opportunité pour saluer les efforts de tous les acteurs engagés pour le développement et la promotion du bien-être des enfants. La problématique qui nous réunit aujourd'hui, à savoir mettre fin aux inégalités à l'égard des enfants dans le cadre de la réponse au VIH, constitue un défi majeur dans la réponse au VIH tant au niveau global, régional qu'à celui des nations et particulièrement des nations africaines. Selon le rapport mondial 2020 de l'ONU-SIDA, 38 millions de personnes vivaient avec le VIH, dont 1,8 million d'enfants. Parmi ces derniers, à peine 53% ont eu accès au traitement antirétroviral contre 68% d'adultes. Le taux de décès chez les enfants est de 14%, alors qu'il ne représente que 5% chez les personnes adultes vivant avec le VIH. L'Afrique porte le lourd fardeau du VIH avec 90% d'enfants atteints de cette maladie au monde. La couverture au traitement et le taux de suppression de la charge virale chez les enfants vivant avec le VIH demeurent faibles comparativement aux adultes dans la plupart des pays africains subsahariens à haute endémicité. Dans mon pays, seulement 34% d'enfants vivant avec le VIH ont accès au traitement antirétroviral contre 66% d'adultes. Au vu de ce tableau préoccupant, j'en appelle à un engagement fort des États et des partenaires pour des actions à haut impact visant à améliorer l'accès au dépistage, aux soins et traitements, ainsi qu'à la mesure de la charge virale chez les enfants vivant avec le VIH. Mesdames et messieurs, j'exhorte également les États africains à fournir des efforts pour la production locale des médicaments antirétroviraux avec l'accompagnement des agences du système des Nations Unies. La promotion de l'accès universel des enfants au traitement optimisé et la mobilisation des ressources domestiques pour la riposte au VIH. Pour mon pays, nous sommes engagés, avec l'appui des partenaires techniques et financiers, à mobiliser des ressources pour améliorer la couverture dans le système de dépistage précoce du VIH, ainsi qu'assurer l'accès équitable aux soins et au traitement des enfants. Mesdames et messieurs, dans l'espoir que les conclusions qui sortiront de ces travaux permettront d'assurer un avenir meilleur pour les enfants vivant avec le VIH, je déclare ouverte cette session. Je vous remercie.
Well, while we're waiting for our IT fix, I am just going to take the prerogative and mix things up a little bit. So Chip, I'm going to give you a little bit of heads up here. You know, we have these two videos, and then we have a wonderful video of a youth dialogue. And that was to wrap up a little bit then with our final speaker of this session, who is Chip Lyons. Chip is president and CEO of the Elizabeth Glaser Pediatric AIDS Foundation, which has been a stalwart advocate for the needs of children and women throughout the years. So with that, Chip, let me go ahead and ask you to give your remarks now, and we will catch up on the videos after. Over to you, Chip.
Thanks, Shannon. Can you hear me okay?
Yes, you are good to go.
Okay, great. Thanks. I'm going to proceed as if the other speakers and videos had been presented, if you'll allow me, including a little formalities at the beginning. But I do want to acknowledge Excellencies, distinguished leaders, honors guests. It's a real privilege to be with everyone today. The panel, the quality of the speakers assembled, and the other speakers in the program to discuss children and HIV is a hopeful and welcome sign. EGPAF was encouraged by the recent UNAIDS strategy, which clearly articulated a harsh but accurate reality. One of the most glaring disparities in the HIV response is the failure to meet the needs of children living with or at risk of HIV, as you noted, Shannon. Viewing the UNAIDS strategy through the inequality lens that it provides, we see children in the foreground, most needing deliberate actions. New pediatric HIV infections are on the rise in a handful of countries. Pediatric treatment coverage is stalled. And as shown by the latest UNAIDS data, the gap between pediatric and adult treatment coverage continues to grow. Countries and partners have failed to identify and reach almost half of the children living with HIV. Each of us here today is committed to a common goal, ending AIDS as a public health threat by 2030, but we're sorely off track. That target can only be met if we work with serious purpose and innovation to get the greatly improved prevention tools, medicines, and knowledge to those that need them most, while doing so in the context of protecting rights and ending stigma. This same approach must extend to children who are never quite viewed in the same light as adults living with HIV. Without a voice in the response, children can't demand the actions, the services, the solutions to their needs. And so it is essential that we all put children forward to break the pattern of leaving children behind. This is particularly true in Africa, where 90% of children living with HIV reside. Yet a sense of complacency on the pediatric HIV agenda is threatening to take hold. After almost 20 years of global and national leadership and investment, one thing is clear. The sheer magnitude of the impact HIV has had on the people of Africa makes ending AIDS in children and youth almost by definition an African challenge that needs African-led solutions with international support. Realistically, if we can't end AIDS in children, what chance do we have of reaching the 2030 target? In fact, we can end AIDS in children with the tools and knowledge we have in hand. We're at a place where the question really is, will we collectively choose to do so? Elizabeth Glaser once said, sometimes in life, there's that moment when it's possible to make a change for the better. This is one of those moments. Let us use this very moment, 40 years after the first case of HIV, as a turning point on behalf of children, mothers, and families everywhere, driving tangible change on the technical approaches, the political will, community strategies, and resources needed to get the job done. Thank you.
Chip, thank you so much. And thank you for your tireless work for EGPAF. I think we all rely on EGPAF as a stalwart advocate partner and really a true north If we ever want to let up or give up, we know that among other voices that we're going to hear today, certainly we can count on you to really right us with our urgency and direction.
Thank you.
So we're going to go ahead and continue with our live panels while we work out some of the tech issues. So for our first panel, I'm going to welcome and turn the moderation over to Dr. Meg Doherty from WHO. Mahesh, I'm going to do a quick check-in with you. Should she go ahead and share the slides directly, or are you still able to share them? I'm sorry?
Yeah, I would share the slides from my side.
Okay, great. Go ahead, Mahesh.
But
So
if there is an issue, we will stop sharing the slides.
Great. So over to you, Meg.
All right, thank you very much, Shannon, and also Chip and all the speakers to come, because we were very, very pleased that we had a video from our region.
To address the inequities
our regional director from Africa, who was who also was able to join this session virtually. So we are very much looking forward to later from WHO to hear some of these events and these sessions. On this first part and the first session, we're tackling inequities in innovation and how these are going to help us with the pediatric HIV/AIDS response. And what we will hear from five-minute rapid fire presentation will be focused on the evidence-based action that we'll need to be able to make our targets that we have committed to. So right now it's my great pleasure to introduce Dr. Anjali Mugo, who will be presenting on the path to elimination, closing pediatric gaps in countries, rethinking the EMTCT and vertical transmission services in countries, and improving pediatric case finding, treatment initiation, and viral suppression from infancy to adolescence. And Dr. Anjali comes from the Ministry of Health of Zimbabwe, is our co-chair of our validation committee for elimination of mother-to-child transmission, so is the best expert to speak to this. Over to you, Anjali.
Thank you, Meg, for that introduction. And I wish to say good morning, good afternoon, and good evening to all the listeners on the call, and certainly all protocols observed. We continue to count numbers, and it is really disturbing to note that in 2020, we had 160,000 new HIV infections among children. And I say it is truly an injustice that in this day and age, we have all the armamentarium that we need at our disposal to prevent vertical transmission. And what I will show you in the next slide is some of the data that is from a country where we are moving to attain elimination of mother-to-child transmission of HIV. So Zimbabwe is, as you know, a high burden country with an HIV prevalence of 11.93%. And we recorded in 2020, 5,113 new HIV infections among children. Our transmission rate at the moment is at 8.7%, and yet we want this to be less than 5%. This is despite fairly high coverage of antenatal care attendance of 93%, high ANC testing of pregnant women, more than 95%, and then ART coverage for PMTCT of 90%. And I note that in the last year of 2020, the COVID-19 pandemic has not spared us, and already the impact on EMTCT indicators has begun to be felt. ART coverage for PMTCT dropped 2 percentage points from 2019 to 2020, and right now we are at 88%. We know that globally, 15 countries before us have been validated for elimination of mother-to-child transmission of HIV, and as a country, we are certainly aspiring to reach the gold tier on the path to elimination of mother-to-child transmission of HIV. Now, while progress has been made, we still see some significant drivers of new HIV infections among children, as per the UNAIDS tag bar, which is demonstrated on this graph. Essentially, what we know and what we can see are the drivers of new HIV infections in our country is mothers who are not on ART. They are not initiated on ART. They are pregnant and breastfeeding not on ART, or they are on ART and then they drop off of ART. And we have this concerning dynamic where we've got new HIV infections in pregnant and breastfeeding women who were previously HIV negative. Now we know that with political commitment, with adoption of some of these game changers, we can actually make a difference in terms of these new HIV infections among children. So what we see as the key interventions to reduce new HIV infections in children is really identifying all women living with HIV and having them, all of them, on ART. It's about retention and care and viral suppression in HIV positive pregnant and lactating women so that we reduce the risk of transmission to a minimum. And of course, importantly, targeting the adolescent girls and young mothers in our programs and other women of childbearing age so that we prevent new HIV infections among children. Speaking to the issue of antiretroviral treatment coverage and the disparity between adult coverage and pediatric coverage, you see that in Zimbabwe, our adult ART coverage in 2020 was 90%, and for children sitting at 73%. So those global disparities are really replicating themselves. And we can see to what extent we are inconveniencing and prejudicing our children and the future generation of children. So what is it that we need to do? And in the next slide, I think you will see some of the interventions that could be game changers as we move forward to end AIDS by 2050. So how can we innovate towards elimination of mother-to-child transmission? I put some priority interventions for EMTCT, such as prevention of incident infection, pre-exposure prophylaxis in adolescent girls and young women, and then having creative strategies, differentiated service delivery models to enhance adherence and retention in care of HIV-positive pregnant and breastfeeding women. And in Zimbabwe, we have these young mental mother initiatives. We have adolescents who are providing peer support to their fellow adolescent colleagues. We also have mother support groups, these Mbereko groups that tie in men to make sure that we can push forward the issues on retention and adherence. And as far as pediatric ART is concerned, of course, we need to intensify case-finding approaches for children. We can deploy some of these innovations, such as the point-of-care early infant diagnosis platforms, to get the infants early as at birth, according to our updated EID algorithms. What about those more than 5 years who have not been found? Obviously, we are not going to find them on the PMTCT platform. And therefore, we have to expand in other entry points for testing. We have to look at family-based index testing, community-based testing approaches, and even HIV self-testing, so that we can broaden the base and reach and find the missing children that are yet to be put on antiretroviral treatment. And of course, it's important to strengthen clinic community linkages. This is really critical because we cannot do it alone in a health sector-based strategy. We have to work with communities. Now, in the next, sorry, this is my last slide, but what I just wanted to highlight is the stark inequalities that I have presented and that we have heard from speaker after speaker that are leaving our children behind. And so what I think is we should do business unusual if we want to end AIDS in children by 2030. And so in closing, I would wish to acknowledge the collaborators who put this session together. I thank you all for your attention. And it is my hope that as we do our work moving forward, we will not leave our vulnerable children behind. So thank you very much to the organizers, and thank you all for your attention.
Thank you, Angela. You highlighted in your brief presentation that in Zimbabwe, you know what the gaps are, you know what the innovations are to address those gaps. And really, we need to find both the political will, the community will, the donor will, the partner will to really ensure that those innovations are used to their maximum capacity. So thank you very much. And I think we'd love to see that kind of innovations coming out from other countries using the data as you're doing. Next, taking that same theme of looking at how we can ensure that pregnant and lactating women remain free of HIV and how they can stay negative, it's my distinct pleasure to invite Dr. Nelly Mugo from the University of Washington, but who is also based in Kenya, who will make her brief 5-minute intervention. Over to you, Dr. Nelly.
Good evening. It's my pleasure to be able to speak to you today, and really thank you for inviting me to speak to this session. So next slide, please. What I want to start off by saying is that to keep pregnancies free of HIV, to keep pregnancies HIV negative, we'll really need to focus on young women. And there's been a lot of discussion about the youth belt in sub-Saharan Africa. We know that 20% of our population is between the age band of 15 to 24. We also know that this is the peak fertility period. Additionally, from recurrent UNAIDS data and country level data, we know that young women between the age of 15 to 24 are twice as likely to get HIV infected as men. We've also learned from actually global HIV/AIDS statistic that women and girls in our region account for 63% of all new HIV infections. And 6 in 7 new infections amongst adolescents 15 to 19 years are among young girls. So I want to posit that in our design of interventions and delivery strategies for HIV prevention in pregnancy, we must maintain a focus on young women as our focal end users. We must understand their perspectives. We must understand what strategies will reach them and that they will respond to. So another thing to keep in mind, all addressing this whole issue of the youth belt, is that we've been told that this population group will double by 2050. So as we focus on keeping pregnancies free of HIV, even what's working now, we must double our efforts because the group, the total population in that basket is going to grow larger. Next slide, please. So in the next slide, I really want to move on to the positive. In the last couple of years, it's actually been called literally the golden age for HIV prevention. We have the promise of long-acting, highly potent, less user-dependent HIV prevention and treatment strategies. Now we know treatment is key to prevention, and ARV treatment, effective viral suppression, is highly important for keeping children to be born HIV-free. It's also been a period where we've learned a lot about self-testing. And I'm not sure that we have enough data that really demonstrates to us how we use self-testing in the environment of antenatal care services. How do we optimize finding new cases and finding HIV negative women and increasing the number of women who know their status at that time, and knowing the women who are at risk so that we can present to them the interventions that we have in hand. The interventions we have in hand is treatment and prevention. And what we have now are highly effective tools for treatment. Now in this golden age, we have very exciting new data. Very recently, we got the Carbotegravir data, which is an integrase inhibitor, injectable every 2 weeks, was shown to be 87% more effective than oral pre-exposure prophylaxis, which we already knew to be highly effective, but had the challenge of adherence to a daily tablet. Even more interesting is that there's a lot of progress and information on formulating these prevention interventions into long-acting products in implants. And if you look at the HIV-R4P data, you see that there's work being done in developing a Carbotegravir implant. The Islatravir monthly pill, again, really exciting, is highly potent, has a long half-life, has a high barrier to resistance and very little drug-to-drug interaction, and no food restrictions, is now going to be evaluated in a phase 3 trial, both in the US and Africa, for both efficacy and safety. We also have another product, the lenacapavir, which has been evaluated as subcutaneous product, which is a new in-class capsid inhibitor, again, highly potent, low potential for resistance. And I find this a really exciting product still for keeping women free of HIV in antenatal care, at twice yearly dosage with a subcutaneous jab. That means that a woman only needs to be given this twice a year, while the oral pill is just every month. So you can do this as a point of care product. And that is being evaluated in the HIV Women's Prevention Study. We also have interesting data in broadly neutralizing HIV antibodies, and we have the HPT and AMP results, which were again recently presented. They demonstrated proof of concept for efficacy in specific HIV strains. The dapivirine ring has moved and has been approved by the WHO as a monthly intravaginal product. And we have other multi-purpose technologies. Now, what I want to bring up is this question: in all these trials, in all this data, where was the consideration for pregnant and breastfeeding women in study designs? And that's a question we need to push in advocacy. And what is the impact on time to access for effective products? That all has to be balanced on what influences women's decisions in use of pre-exposure PrEP products during pregnancy. Again, of course, we know that there are ethical issues about using products in pregnancy. But if we don't think about it early, as we start these trials, if we don't keep pregnant breastfeeding women in mind, then they're going to be very far off the track in gaining access to safe, effective, highly potent, user-friendly interventions to keep pregnancies free from HIV. So thank you very much for your attention and this moment. And I hope that we will change this and we can truly have a future of children born free of HIV as they deserve to be. Thank you.
Thank you, Dr. Mugo. And I think you gave us just a really quick overview of what we're seeing, sort of a buffet of options. And we know for both prevention, for contraception, for having ARVs that are optimized, that choice has seemed to be now very important as we move forward. And I think what we're seeing on the horizon are lots of choices. And hopefully with those choices, we'll be able to ensure that young women, older women, women who are pregnant are actually able to access both prevention through medical choices of PrEP or using a dapivirine ring or a subcutaneous class of drug. I think this is just such an important piece of work that we need to use as we move forward. So thank you. And I think that era of looking towards optimizing new drugs and transitioning to the best regimen will be brought up by our next speaker, Dr. Owale Federa from ICAP, who will be talking about the experience of transitioning to dolutegravir for children in Nigeria. So it's my pleasure to pass over to Dr. Federa. Thank you.
Thank you, Meg. Good afternoon and good evening, everyone. I'd like to thank the organizers for the opportunity to share our story from Nigeria about how we optimized antiretroviral therapy for children aged 0 to 19 years. The RISE program supports about 4,200 children through 101 HIV treatment sites in 4 states of the 37 states and territories in Nigeria. This represents about 6% of the total recipients of care on our program. The children were enrolled over an 18-month period, specifically from October 2019 to March 2021. In the period under review, RISE teams were able to reduce the proportion of children on nevirapine and efavirenz-based regimens from 33% and 5% respectively to less than 0.5% for each regimen, while simultaneously increasing dolutegravir-based regimens from 58 to 70% and abacavir, lamivudine, lopinavir, ritonavir regimen from 4% to 29% in the period. The cumulative outcome was such that by March 2021, 99% of the children and adolescents on the RISE program, less than 19 years, were on optimal antiretroviral therapy. DTG uptake for our children less than 9 years was at 70%, and the remainder of the children were on lopinavir, ritonavir-based regimen, because we were now able to use weight-based dosing for children who are less than 5 years old, who would otherwise have been ineligible for DTG. While there were other contributing factors, we saw a direct correlation between the increased use of optimized antiretroviral therapy regimen in children and adolescents and the progressive increase in our HIV viral suppression in this age group. Within the period under review, the proportion of children 0 to 19 years who are virally suppressed increased from 53 to 80% for the 0 to 9 year age band, 66 to 85% for children aged 10 to 14 years, and 73% to 87% viral suppression for adolescents 15 to 19 years old. Now, it's important to note that the most dramatic increases in viral suppression were recorded in the younger age bands, with whom we initially struggled because of restrictions to the use of DTG in this age group until we're able to use lopinavir, ritonavir-based regimens that we could do appropriate weight adjustments for the dosing. On the RISE program, our current protocol for ART initiation for all newly diagnosed children and adolescents is to start with an optimized regimen as our minimum standard of care. Next slide, please. So with respect to our methods for achieving this level of treatment optimization, I'm really excited and proud to say that the main driving force was the teamwork. The RISE team had a shared vision and a common understanding and the need to prioritize our regimen optimization strategy as the means by which we're able to provide this high quality of HIV care for the children. Our strategies could be grouped into 4 main domains, which were designed to address the factors that limited regimen optimization. And the key strategies from these domains, which are basically programmatic, environmental, client and pharmaceutical factors. The key strategies I would like to highlight, first of all, there is the healthcare worker training and retraining, particularly for pharmacy teams and case managers. And because of the COVID-19 restrictions, we had to leverage on virtual training platforms like Project Echo. I've already mentioned the role that having weight-based dosing for children who are less than 5 years old played, but also the fact that the availability of lopinavir, ritonavir pellets made administration and the palatability issues with older formulations. It resolved those issues and we're able to ensure better administration of the formulation. Then, of course, circumventing the movement restrictions due to the COVID-19 pandemic last year was a major success factor. And we achieved this by obtaining work passes and PPEs for healthcare workers and frontline teams, such that they could ensure that children were refilled even when they were at home. We made weighing scales available to community teams so that we could do clinical assessments even when teams were outside of the facility and ensure that appropriate dosing was made available to different children. I think treatment literacy and adherence preparation for caregivers and older children was also a key success factor, as well as disclosure preparation, peer-led support groups, and ensuring that each of these children was tracked at a granular level. Their treatment outcomes, ART initiation, viral load levels were tracked on an individual level. And this information was used as part of the counseling support. I think something that was a game changer for us was the use of an asset-based and community embedded strategy called Operation 000, or OTZ. OTZ aims at 0 missed appointments, 0 missed doses, and 0 viral load. And this was used as an empowering message for the youth and the caregivers. And it was set as a goal for all members of this, would I say, club to aspire to. And that helped us guide them towards the kind of adherence and treatment compliance that we wanted to see. There were a few issues at startup regarding ARV availability, and it was really reassuring to see the responsiveness and distribution of ARVs, either at regional level or at national level, and we're able to deal with that. I think something that was key for our pharmaceutical intervention was the introduction of a pause model, such that in the clinic flow, service delivery for children would be halted if a healthcare worker realized that a child was on an unoptimized regimen. The clinic flow would be paused and that child would be transitioned to a more optimized regimen before we would let that child leave the health facility. So these are just some of the highlights of the success strategies that we used. And I think as a team, we're really excited by our achievements in our pediatric program, and we look forward to elaborating on our experience and our results. Once again, I'd like to thank the organizers for the opportunity and the platform. Next slide. And specifically appreciate our team in RISE Nigeria, particularly the pediatrics clinical team from ICAP and our pediatric and adolescent recipients of care and their caregivers. Thank you for your attention and do enjoy the rest of the session.
Thank you. That was so impressive. And I feel that when we heard the numbers earlier, that we have a disproportion between adult viral load suppression and childhood viral suppression. We just need to take your model and transport that into all the countries, because you addressed the ARV, the optimization, using the weight-based, you looked at DSD models to include and to improve adherence, including taking it to the home and using all sorts of ways to stop clinical care if the child was not getting the best regimen. So just hats off to you. And I think this is the kind of innovations that we need to see. It's not just drugs, but it's the entire clinical and service delivery package. So with that, that brings us to a next presenter, Dr. Martinez Panasato, my colleague here at WHO, who will be speaking about accelerating the development and accessibility of child-friendly ARV formulations. So I think she is uniquely placed to give us a sense of how do we do this better? When can we bring in the next optimized regimens as we move forward? Over to you, Martina. Thank you.
Thank you, Meg. Good afternoon and good evening, all. We know that in the last 10 years, infants and young children in many parts of the world have too often been denied access to child-friendly formulation of optimal ARVs to ensure effective and durable treatment response. The delays we have observed are due to multiple reasons, but they are not acceptable anymore, and a conceptual shift is needed to change this once for all. And today, we know how to do so because we've started to do it. Next slide. Dolutegravir was first introduced in WHO guidelines thanks to the strong collaboration of rapid data sharing of pediatric research networks, which allowed WHO to include a simplified dosing approach and recommend dolutegravir for all children with approved dosing. Countries responded rapidly, and by July 2019, 18 of the 21 free priority countries had to revise their national policies to include dolutegravir for children above 20 kilos. In June 2019, thanks to the accelerated submission plan by the innovator, dolutegravir was approved for children older than 4 weeks and weighing at least 3 kilos, finally allowing implementation of existing WHO guidelines. Wide access to more than 135 countries included in existing licensing agreement became possible thanks to the approval of the first generic version of dolutegravir 10 milligrams core tablet, for which a groundbreaking agreement granted a price that reduced by 75% the cost of treatment for children. Today, thanks to the use of regulatory reliance mechanisms, catalytic procurement, and the collaboration of implementers and procurement agencies, 4 countries have received dolutegravir 10 milligram, and 19 countries will receive it by the end of the year. Next slide. So dolutegravir is not just the core ARV drug in WHO recommended regimens finally becoming available to all children in need, but it's the symbol of how we can get better ARVs to children more quickly. It's the reminder that if innovators work closely with research networks to implement targeted and strategic research and rapidly share this critical evidence with regulators and policymakers, approvals can be accelerated and global guidelines can be timely revised to ensure scientific innovation gets to children as quickly as to adults. Is the reminder that when donors, international organizations work closely with suppliers and innovators, we can develop affordable and accessible generic pediatric formulation new ARVs and even get approval for those formulations as quickly as a few months after the innovator products, allowing equitable access to better drugs for all children living with HIV globally. Dolutegravir is also the symbol of a coordinated and collaborative effort to make sure that once these products are developed, they don't remain on the shelf, but are effectively delivered to countries where guidelines have been timely adopted and healthcare workers are already being trained and prepared to use the new formulation as soon as they become available in the health facility. It's also an example of how the community of people living with HIV can mobilize to make sure that families are informed and given the opportunity to understand why a new formulation is of value for their children and are able to demand for these products when they get to the clinic next. These are only some of the lessons learned over the last few years, but these are the lessons that can make sure that those long delays we talked about are a bad memory of the past. Country governments, particularly those in sub-Saharan Africa most affected by the HIV epidemic in children, have a critical role to play in enabling that final and most important step of the product life cycle by utilizing the existing reliance mechanism to accelerate national registration and taking better formulations where they're needed, setting up the appropriate mentoring and monitoring to support safe and effective use of these drugs. Now is the time to accelerate this work on the ground. Global partners are coming together to consolidate and solidify this lesson learned through a collaborative platform such as the Global Accelerator for Pediatric Formulations, which we in WHO have the honor and the responsibility to host, but also through a pivotal political platform convened by the OEC and other partners where technical work led by many stakeholders is elevated and translated into real commitments to be accountable to. Today, I think that we stand stronger of our progress, but with additional responsibility to continue to hold hands and ensure that the change that we were able to generate with dolutegravir becomes the new norm, the new standard to reach treatment targets by giving more treatment options for children to survive and reach their full potential. Thank you very much for your attention.
Thank you, Martina. Incredibly impressive story of dolutegravir, but that we look for the future that it will be taken to other ARVs for children, and certainly towards the challenge that Dr. Mugo brought up is the drugs that we need for both prevention and treatment in pregnant women and breastfeeding women. So it's excellent work. Now it's my distinct pleasure to introduce Luann Hatane from PATA. She'll be speaking about meeting the unique needs and circumstances of children and adolescents, comprehensive clinic and community models, integrating health, wellness, and HIV services, taking into account the COVID-19 era. Over to you. Thank you.
Great. Thank you so much, Meg, and thank you to the organizers. From the previous presenters, it's most certainly clear that we have the tools, we have the treatment, we know what to do, and we definitely know what works. However, bringing it all together in one comprehensive package in a way that's holistic, affordable, contextual, and able to respond to the individual and unique needs of all children and young people is a lot more complex, especially when we add COVID-19 into the mix. So despite these additional stresses, we have seen many clinic community delivery models not only working well, but also offering a platform to tackle COVID-19 alongside HIV and many other public health challenges. These are the models that offer the greatest return on our investments and have shown us how to integrate health, wellness, and HIV services better in the COVID-19 era. These models focus on clinic-community collaboration, service integration, and differentiated service delivery that is person-centered, child and adolescent-friendly, and is supported by task-shifting and multi-sectoral approaches. Expanding treatment access has relied on nurse-led ART initiation and management, which has shifted non-clinical roles to community partners. Along the cascade, we have seen the benefits of village birth attendants, community health workers, peer educators, community and faith leaders who provide information that is relevant, who mobilize and sensitize communities, drive prevention and service demand. This same cadre have supported COVID testing, tracking and tracing and provide much needed emergency relief for affected communities. COVID has further pushed us to decentralize and reorganize our clinics and manage caseloads differently with the adoption of more differentiated service options. We have seen virtual case management, file reviews, fast-track ART pickups with multi-month dispensing extending to infants and children. This decanting has been supported by community art models such as baby clubs, teen clubs, and family days, designated appointment days with integrated sexual and reproductive health for adolescents and young people, as well as mother-baby pair service integration, has all strengthened efficiencies and convenience. Peer support models have further provided adherence and psychosocial support, have helped tackle mental health, gender-based violence, which COVID has shown us to be critical elements in a package of care, where community partners and cadres continue to offer a critical link and referral pathway. Technology has also become increasingly part of service delivery when managing COVID and HIV. We have seen how bot-enabled SMSs have the potential to share information quickly and at scale. We have seen an expansion of virtual file reviews, case management and training. There's been increased use of telemedicine, expanding platforms for prevention and self-care. We have seen psychosocial support being offered in closed virtual groups through mobile apps, WhatsApp, Facebook. Mobile health, integrated record keeping, tracking and tracing with direct lab notifications are also advancing. So whilst access, data and privacy continue to be limitations, virtual platforms are an important complementary tool when used in targeted ways. Like point-of-care technologies, we have seen how mobile health can be a game changer in turnaround periods for HIV and COVID testing and management. Next slide, please. These models provide examples of transforming health delivery through local partnerships, but we still need greater leadership, investment and capacity to improve how clinics and communities work together in a coordinated and accountable way, to better share and use data together, as well as plan, deliver, and monitor services together. Much, much more must be done to protect and invest in health and care workers and community-based organizations as a public health good. They require the skills, the tools, the resources to accelerate COVID recovery, to roll out vaccines and offer HIV services that are optimal, inclusive, accessible, integrated, tailored, and people-centered. Lastly, we need to shine much more light on frontline voices so that they influence and inform our conversations in leadership and decision-making. They know what works best, and it's time for us to really follow their lead. So with those closing remarks, thank you so very much. Thank you.
Thank you very much. Excellent words to end this session, and fantastic session, everyone. Thank you. It's my pleasure now to hand back to Shannon.
Great. Thank you, Meg, for such a great panel, and thank you to all the panelists. Now we are going to try to make up a little bit of time here. And so the first 3 videos that we missed, we are just going to, Meg, I think, is going to arrange to have them posted on the web so that you'll be able to see Dr. Jean-Jacques' comments, Dr. Four's comments, and Dr. Moedi's comments. But we do want to set the stage for the next panel. And we're going to do that by turning to a video that is sharing the voices of those that we're focused on helping. So please, we'll turn it over to video 4, which is our youth dialogue, listening to the voices of the people we need to serve. So let's see if we can make this work.
As a young girl, I was enrolled into a psychosocial support group.
Give us a second. We're going to give it one more shot. And Che-Wei, I'll just have you on deck for the next panel, and we'll be ready to go to you if we aren't able to get the video going. But it's a really good video, so I want everybody to see it.
Okay. Hello, everyone. You're most welcome. My name is Josephine Kenya. I'm from Uganda, and I was born with HIV 27 years ago. When I learned about my HIV status as a young girl, I was enrolled into a psychosocial support group, and this was called Aerial. It was named after Elizabeth Glazer's daughter. Since then, I've dedicated my entire life to helping other children and young people like me. I have a bachelor's degree in social sciences from Makerere University, and I've earned this and used it to support children, other young people to overcome the realities that HIV presents. With me right now, we have a panel of amazing women and children, and they're here to share their personal stories as we seek to discuss what exactly it will take for us to create an AIDS-free generation. So allow me to start with Babs and Nati. Babs is a mentor mother with Mother to Mother, and her daughter was born HIV-free. Babs received this support during the time when she was pregnant from Mothers to Mothers. Babs, you're most welcome on this panel, and I would love you to share your journey from being a newly diagnosed pregnant woman almost 20 years ago to a healthy worker and a role model in South Africa.
Thank you, Josephine. My name is Baba Lompono. I'm from South Africa. I'm a mother who's living with HIV for more than 19 years now. Through my HIV journey, I was diagnosed when I was pregnant. I learned about my status during my antenatal care visits. One of the doctors that used to see me is the founder of Mothers to Mothers, who is Dr. Mitch Besser. Mitch Besser is the doctor that was able to introduce me to Mothers, mentor mothers who were in the facility where he was working. I was very happy to meet these women, although I was scared. So due to the information and knowledge that I received from those mentor mothers, I was able to adhere to my treatment and have a beautiful HIV-free child. So after that, I was interested to come and join Mothers to Mothers so that I can share my own experience and my journey, and also provide more knowledge and education to those women who are newly diagnosed, who are also going through the same fear that I went through when I was also pregnant. I learned to educate and support other women so that they also can be empowered to live HIV-free, have HIV-free children, and also live positively with their families. As of today, I'm still a role model to those women. Then I can also share those experiences with those children.
Indeed, there is nothing that is more beautiful and more supporting like getting support from a person that has gone through the experiences that you're going through. And Nathi, as a teenage girl in South Africa, how do you talk about HIV prevention when you're with your peers?
Being a teenager in South Africa is quite difficult based on the peer pressure that we always get. We experience things that are out of our control. And sometimes those things lead to unplanned pregnancies and also STIs that prevent us from growing or prevent us from doing things that we want to do in our lives. A lot of the times we are not educated enough about what we should not do as youngsters, and sometimes it's difficult to even open up to a young mother or even just mothers out there, because we feel that we are going to get criticized for even talking about sex. Aside from the COVID pandemic, we also have a HIV pandemic and unplanned pregnancies, which also lead to dropouts and some girls thinking that they should be supported by men instead of standing up for themselves. It's a lot, but we need to teach young girls how to be independent and motivate them to do more.
Thank you so much. Indeed, we need to make people comfortable to, talk about HIV freely, because the more they talk about it, the more you get to demystify the myths and misconceptions around that they are believing in. So thank you so much for that wonderful work. Allow me now proceed to the other panelist called Doreen. Doreen is a young woman who was born with HIV and has since then grown into a healthy, active inspiration for her peers. So Doreen, we would love to hear from you. How did you navigate learning about your status, and why is it so important to advocate against stigma?
I come from a discordant family. My dad is negative, my mom is positive, and I'm the only one of my siblings living with HIV. But when I finished high school and I realized that now disclosing my status was a challenge, people did not look at people living with HIV as normal people, because living with HIV has been seen as a sin. And it's almost 40 years since HIV has been with us in the world. And people still look at it as a promiscuous disease. I am sharing my story to tell people that we are living beyond our HIV status, that I have been here for the last 28 years and I'm not dying. So that is one of the things that I need to break, that barrier of stigma, because the donors and all the policymakers have come up with this ambitious plan of 95, 95, 95. But the elephant in the room is the stigma. If we have not killed stigma, people won't take the medication. If we have not addressed stigma, people will not be virally suppressed. And if we have not addressed stigma, people will not get tested and know their HIV status, because they still fear HIV. But by sharing my lived experience, I get to tell people that this is my journey, this is my life, and I've lived with it for my whole life. It's not an easy journey, but we are human beings, we are not numbers.
Wow, thank you so much, Doreen. By the way, I have to let you know that I'm one of your fans on Instagram, so I follow your posts, and I'm really happy with the work you're doing on social media. Allow me now proceed to Miriam. Miriam is a dynamic activist for young mothers in Uganda and internationally. And she has played a very big role in creating an advocacy agenda outlining what needs to change to support adults and parents that are affected by HIV and their children. Miriam, can you share with us about your life journey today as you go to school, raise your son, and address the challenges of being HIV positive?
Yeah, we all need to put young families first, because they are a crucial and a growing population in the world. In my country, Uganda, very many young mothers or young families are discriminated. We are treated as outcasts. We are treated as sinners in the community. When I got pregnant when I was 15 years, I was forced to leave home, not because I wanted, but because of the discrimination, because of the neglect from family members and friends. So my grandmother came to my rescue. I thank God that I gave birth to my baby boy, and he's now 5 years. So what I can tell donors is that they should encourage us, they should treat us like other people, they should put young families first, and they need to involve us in their talks and also give us empowerment. Like they should empower us more than discriminating us. Thank you so much.
Thank you so much, Miriam. I'd love to thank all my other panelists, Miriam, Doreen, Babs, and Nathi, for sharing your personal stories and for sharing your work with us, because I believe that it's from such stories, from such life experiences, that we are able to make decisions that will enable us to see an AIDS-free generation. Thank you so much. God bless you.
Well, I'm so glad that we didn't miss that virtual panel of the young women who have a lot of insights for us. So thank you everybody for your patience. And I don't want you to miss this next panel. It's going to be fabulous. I'm going to introduce Dr. Chewe Luo of UNICEF, who's going to lead this next section, which is another roundtable discussion of a lot of experts on this topic. So Chewe, over to you, please. And you are muted. So if you can unmute yourself, we'll be all ready to go.
Thank you. I know that we're running out of time, but thank you for the excellent panel of our future leaders, our future voices for pediatric HIV. We've come a long way, and seeing these young people speak for themselves just reminds me how long we've been at this game of trying to end AIDS in children. We have heard a lot of progress in the science, but also in implementation of our global efforts to end AIDS in children. But we've also heard inequities that still remain and persist, that hinder us from making the progress that we want to make to advance elimination of vertical transmission, as well as advance quality treatment for children. And we're also being asked as we speak this week around the high-level forum, the need for us to be more precise in what we do, more targeted in what we do. Moving forward, we really need to rethink our programming approaches. So with that, I just want to say we have 7 speakers. I hope everybody's online. And each of the speakers will tell us, give us their 2-minute, 3-minute high-level pitch around what we need to do to change the course. So I start with, we're going to have the head of health in at the AU, Margaret Agama, but I understand she's not with us and somebody has replaced her. And so with that, I just wanted to say, we need political leadership, and we've talked about that. We know that 90% of the 1.7 million children living with HIV reside on the African continent. So I'm trying to figure out who has replaced, but I don't have the name in front of me. But from the AU perspective, what do we need from our political leaders to change the course on elimination of mother-to-child transmission? We heard the eloquent presentation from our colleague, Angela Mushavi from Zimbabwe. But from the AU perspective and the African leadership that we need, what we need to do.
Good morning, good afternoon, and good evening, ladies and gentlemen. All protocols observed. My name is Sheila Shawa, and I'm just stepping in for Dr. Margaret, who unfortunately could not make for this meeting. So I think, first of all, I would like to just thank you for inviting us to this webinar to just highlight some of the activities or some of the decisions that have been put in place by our political leaders in terms of eliminating vertical transmission of HIV. Ending AIDS is a high political agenda on African leaders. This position has been translated into various commitments made by the heads of state and government according to Assembly Decision 320 of July 2010. This decision, in which all the need to promote throughout the continent programs for total eradication of mother-to-child transmission so that no child is born with HIV/AIDS has been underscored, and all AU member states have been invited to intensify efforts relating to antiretroviral treatment and prevention of mother-to-child transmission.
Right.
Yes. The heads of state, I'll just read, it's a statement, so I'll just go through it quickly. It's very short. The heads of state and government endorsed a catalytic framework to end AIDS, TB, and malaria, and eliminate malaria in Africa by the year 2030, to provide an overarching policy framework to respond effectively to the 3 biggest diseases on the continent. The objective of the framework is to intensify the implementation of the 2013 Abuja Declaration commitment to end AIDS, TB, and malaria as public health threats through building Africa-wide consensus on key strategic action within the context of the existing targets and milestones. AIDS Watch Africa is a statutory entity of the African Union created in 2001 with the specific mandate to lead advocacy, accountability, resource mobilization, efforts to advance a robust African response to AIDS, TB, and malaria by the year 2030. And more recently, the African Ministers of Health considered and adopted the draft Common African Position on the 2021 high-level meeting on the General Assembly on HIV/AIDS. This position highlighted the concern of several missed opportunities reaching pregnant women living with HIV on treatment, and this has resulted in the continued HIV mother-to-child transmission rates of 10% or higher in some regions in Africa, and further call the member states to improve access to elimination of mother-to-child transmission services and early diagnosis of HIV-positive infants. Some initiatives of the African Union include the campaign to end new HIV infections in children and keep mothers alive. That's a Free to Shine campaign, which was launched in 2018 to accelerate ending HIV mother-to-child transmission. The Free to Shine campaign also aims to contribute to ending pediatric AIDS by the year 2030 and keeping mothers alive and healthy. The initiative has thus far been launched in 22 member states under the leadership of the Africa First Ladies. The campaign on accelerated reduction on maternal mortality in Africa, CAMA, is an AU high-level advocacy campaign aimed at promoting and advocating for renewed and intensified implementation of the 2006 Maputo Plan of Action to reduce maternal, newborn, and child mortality in Africa. CAMA was designed to bring MNCH issues to the forefront of the agenda of the African member states and was launched on the 7th of May 2009. Moving forward with ending the AIDS agenda, the African Union Commission, in line with the Vision Agenda 2063, the Africa We Want, and the Africa Health Strategy, emphasize the importance of economic returns of ending the burden of disease, and specifically AIDS epidemic as a public threat by 2030. In this view, investment will generate significant benefits among low and middle income countries in terms of well-being. The Commission also advocates for strengthening health systems to sustain the gains in performance, ensuring strong leadership and good governance, forging multi-sectoral partnerships to address the socioeconomic and environmental determinants of health and social protection as critical strategic approaches among many to close the gap in the fight of HIV/AIDS.
Thank you.
Now, these commitments highlight the political leadership and the commitment among us African leaders. Successful implementation of these commitments will result in significant reduction in transmission rates and positively impact the next generation, as they will be free from infection. Thank you.
Well, thank you, Sheila, and thank you for reminding us about the commitments at the AU, not just to HIV, but also reducing maternal mortality and strengthening systems and financing of, and also the leadership that the First Ladies are providing around elimination of mother-to-child transmission. So thank you. I think we have an opportunity with the new outcome document to re-engage with the political machinery of the AU. The next two presenters are from two government programs. We have Malawi and we have Kenya. And I have a question for both of them related to pediatric HIV and closing the treatment gap. So I'll start with Dr. Rose Miranda, who is the director of the national program in Malawi. Rose, in 2019, 74% of children under the age of 14 in Malawi were on treatment, 20% more than what we have as the global coverage of 53%. How has Malawi's focus on pediatric HIV contributed to the country's overall national AIDS response? And what can other countries learn from Malawi?
Thank you very much, Shewi, and thank you to the organizers for giving Malawi the opportunity to share our experiences. Indeed, we've made tremendous progress, and it's largely based on a number of factors. The first one is the issue of leadership and governance at national level. We have a whole specialized National Pediatric HIV Committee, which whose responsibility is to develop policies in pediatric HIV care, guidance, but also they are always monitoring progress in implementation of the policies, guided by the national data which we collect at national level. So Malawi is one of those countries that have got a very strong data system, and this is the data that drives the policies that we develop nationally and even the guidance. So that is just one of the factors. But also this committee recommends even the strategies that should be implemented nationally. And these strategies are based on the gaps in implementation that are observed from the from implementation. Another area is the fact that Malawi has been adopting global guidance. I'll give an example of the acceleration of child treatment, ACT, but also the AIDS-free strategies which were globally shared. These were adopted by Malawi, but also I should mention that in terms of the local context, again, it was the data-driven policies. And these initiatives were implemented at all levels of service delivery. Another area which has helped Malawi is that we were also one of the countries that were an early adopter of advanced HIV disease management for children. I think this initiative allowed our service providers to identify children early and put them on treatment. But also even the scale up of treatment optimization, the better regimens that were recommended by WHO, I think we managed to scale them up across the country as well as, and that helped us to see improvements in viral load suppression. And one other strength about Malawi's HIV program is uninterrupted drug supply. I think we don't experience shortages of our HIV drugs, including even pediatric regimens. So children are consistently having their supplies without interruption, and that has allowed us to have these improved outcomes. What can other countries learn from us? The first one I would recommend is have a strong data system, because that would be the source of the evidence-based policies and decisions that are made. but also collective efforts. I think for us, we have pediatric cohorts across the country, and we need collective efforts by every implementer across the country to implement the recommended policies and guidelines. So collective efforts by stakeholders is key. Availability of POCs platforms, specifically, which we had POCs that were dedicated specifically for EID, and that helped us to have quick turnaround times but also improvement in quality of care for children who are affected by who are HIV positive. Use of mother-infant pairs, that also is a strong initiative, which I think has already been shared by in the video. We have been implementing this. I have already mentioned about scale up of optimal regimens for children. What needs to be done in Malawi? I think that was the last part that I was supposed to share. What needs to be done in Malawi? I think for us to improve the coverage, treatment coverage from where we are, the first point is strong health systems. We need to invest in strong health systems, especially with the COVID pandemic that has slightly slowed the progress. This is a critical area, and we are looking at investment in strong health systems right from facility to the community level. But also the issue of under the same health system, we are also looking at better diagnostics, that is scaling up the POCs. Viral load suppression, for us, we are recommending viral load testing at 6 months monthly, because children are being left behind. This is a policy that we are recommending and we are going to implement soon. But also we need to continue management of advanced disease in children. This is a key area. Retention care, that's also another area that we need to do better. But also improve health care competencies for those that take care of children. They need to have improved skills to manage children that have HIV. These are some of the areas that Malawi needs to do better as we move towards increasing coverage and better outcomes for our children. Thank you very much.
No, thank you, Rosemary, for Malawi leading the charge again. You brought us option B+. Now you're again leading the charge on children. We have a lot to learn from Malawi, but also for highlighting the importance of data and also rapid adoption of global guidance. I think with that, if I can pick it up from the global guidance with Catherine Ngugi, who is also the director of the National AIDS and STI program at the Ministry of Health in Kenya. Catherine, my question to you is related to the fact that you've been at the forefront in Kenya of adopting game-changing innovations in the fight against pediatric HIV, including the use of point of care similar to Malawi, EID, and moving children away from nevirapine to more optimal regimens. What do countries need to do to accelerate introduction and scale up of these innovations at the national level as well as the local level? And what we get more countries, how do we get more countries, as Rose highlighted, to use data to identify and close the treatment gap in children? I don't know whether Catherine is on. Catherine? She may not be. I didn't get a response from her, so maybe she's...
You can hear me?
Yes, I can hear you. Right.
Thank you very much. Thank you for the invitation and opportunity to Kenya to share our journey. To the organizers, Asante, let us speak for the voiceless, our children. Good morning, good afternoon, good evening, and all protocols observed. Our journey as a Minister of Health Kenya with other key stakeholders it started in 2018, especially when we noted that we are lagging behind, especially on low ART coverage. We're around 64%, and poor viral suppression outcomes around 55%, and as well as the first 90, 67%. But on further analysis, root cause analysis, reviewing our programmatic data, we identified some of the gaps. First was a delayed diagnosis of infants. Samples drawn from infants were sent to labs for conversion testing, and results to would take around 8 to 12 weeks to return to the mothers, definitely delaying initiation of ART. And secondly, was majority of our children were on ART suboptimal regimens. That's NNRTI, that is based on nevirapine and nevavirine based, that was associated with high viral load failure rates. So the first question is, what did we do to address the gaps? With support from our partners, we have been able to introduce up to 67 early infant diagnosis point of care across the country. In the sites with the POC, the TAT time now was reduced to 1 day with the enhanced identification and timely initiation of the ART for HIV positive infants. Secondly, the transition of our children to optimized ART regimens. In 2019 and 2020, we made deliberate and intentional decision supported with our healthcare workers to accelerate transition to optimized ART regimens. To prepare the site, we had a sensitization package was developed to ensure that we are able to move our patients from the NNRTI based, as well as we had a national dashboard that was designed to track progress. And I concur with my colleague from Malawi that the data is very, very important. And as of April 2021, of all the children on nevirapine-based regimens have been transitioned to optimal regimens. We have less than 9% of children that remain on the nevavirine-based regimens, and you have more than up to 63% of our children are on DTG-based regimens. And the country is also at an advanced stage to introduce pediatric DTG, a 10 milligram dispersible tablet by September 2021, hoping that around 13,000 clients that we have, we can move them by at least by January next year. A second question was, what are our recommendations to countries on how to best prepare and accelerate introduction and scale up of innovative technologies for pregnant women and children at the national and local levels? First is there's need for strong national leadership to drive the agenda. The National AIDS and STI Control Program provides overall leadership at the national level, as well as established and active a National Pediatric Committee of Experts that identifies priorities as well as track progress. Secondly is this need to quickly align national policy and guidelines to adopt and recommend for newer technologies. As well, but we really need a strong advocacy as well, both locally and national. And also CSOs and communities of people living HIV for newer technologies and optimal ART regimens for children. And again, there's need to establish strong and responsive data systems to track progress as well as impact from national to sub-national levels. And again, invest in capacity building of healthcare workers to support transitions of children to optimal regimens. And in addition, and finally is lobbying with donor resources. There's need for countries to continually advocate and allocate incremental domestic resources to support pediatric HIV care and treatment, which is a deliberate decision we are making as a government to ensure that pediatric drugs are bought by the government. As a country, we acknowledge the good progress, but we know we are not yet there because of the high MTCT rate we have, less than 90% of all the 390s for children, and the inadequate psychosocial support. However, we are determined to bring these gaps, and we thank our committed partners, Ministry of Health, county governments, Global Fund, CIF, PEPFAR, UN Family, ECPAF, among others. Thank you all for listening. Back to you.
No, thank you for the leadership that you're all providing in translating what we know into action on the ground. I know it's not easy, but also for highlighting again the importance of data, but also adapting your policies and actions to the latest guidance and evidence, but also the focus to bring civil society for that advocacy that we need. I'm going to move on to our next speaker, who is Gail Becker, the Deputy Director at the Desmond Tutu HIV Foundation. She has spent her whole life trying to address what we need to end AIDS, or to improve what we know in terms of science for children and adolescents. And it's been nearly a decade of work, more than a decade of work around HIV in children. And we've progressed, as we know, but we've also stalled. So despite these challenges, what encouraging evidence, and we've heard some of it from both Martina, Angela, and others, on the evidence that we have, including Nelly Mugo. But what encouraging evidence from your work in South Africa do you think we need to best utilize to end AIDS in children and also women? And what additional evidence will be needed moving forward?
Chairway and friends, thank you for this opportunity, and it's really terrific to be part of this important meeting. Without doubt, the encouraging evidence I can certainly cite is the monumental reduction in vertical transmission rates, particularly in Southern and Eastern Africa, that we saw up until about 2015. Up until that time, we were following the global plan to end pediatric AIDS with excellent effect in this region. The Eastern Southern region has provided proof that with the right political will, resources, determination, and planning coming together with latest evidence-based interventions, then a goal of the eradication of vertical transmission is in fact a feasible one. Tragically, we fell short of completing this goal, and with this came the needless ongoing transmission of HIV to children. In answer to your second question, in my opinion, no fundamental research gaps exist today. We have all the tools required to eradicate vertical transmission and prevent pediatric infections. To ensure that the tools are deployed in the best tailored, most effective, and most affordable way, there is always room for ongoing program optimization, implementation research, and cost effectiveness. In addition, since it is time to make urgent and sustained progress, then we should expand the vision from just perinatal HIV prevention to a goal of really making a difference to maternal and child well-being and reproductive outcomes in these regions. We should see this as an opportunity to optimize the tracking and retaining of pregnant women and mothers to determine the final outcome of the HIV-exposed infant and to ensure best possible care for mother and child as needed. Ongoing careful monitoring and evaluation of progress and outcomes with attention to age and population segregated data would also help to focus and to ensure that we hold ourselves accountable to urgent timeframes. Thank you.
No, thank you, Linda. You always bring out the best in, how we look at our systems and what we need to do to deliver. And I really like this whole element of, how do we optimize this opportunity to make sure that we're tracking our mothers, we're monitoring our program, and we are enhancing the effectiveness of our program. I think all these things are important. And I think that brings me into the discussion with Siobhan Crowley at the Global Fund, a financing institution for HIV. Siobhan, one of the hallmarks of the Global Fund model is the role of that country leadership and civil society inputs in developing the national proposals. As funds become more and more constrained, what should countries do to ensure that EMTCT and pediatric treatment are equitably resourced? Hearing all the challenges that we've been discussing this afternoon, what roles can low, middle, and high-income countries play in making sure we have increased resources to do all the things that we want to do to close the gaps that we see?
Evening, afternoon, morning, and obviously distinguished panelists and guests. It's a real honor to be with you with such a powerful, passionate panel and with such inspiring leaders, because without you, we've come a long way and we're going to count on you to finish this journey. Indeed, the Global Fund model rests on country leadership. It's the hallmark of the Global Fund and operates through the country coordinating mechanism, or CCMs, as you may have heard. And they're an inclusive governance body where we get government to sit and prioritize with those who live with the diseases, and UN and other partners and constituencies and civil society to help prioritize. I mean, the problem is they do not manage national resources. They have a say over the Global Fund investments, and Global Fund investments at this point are 15% of the global support for HIV, domestic being 44% and other donors about 41%. But when we come to low-income countries, that's about 29% contributed by the Global Fund, with domestic contribution being only at about 11%. So, there's a limit to how much we can expect these CCMs to demand, but they have youth and women and children representation, not always brilliant, but it's there and there's space and room for it. And developing the funding request gives them voice. It's a sort of place where you can use the data and prioritize based on gaps that you see in the program. But we do observe much less demand for children and women to be prioritized. And I think, hearing Linda say from 2015, we took our foot off the pedal, frankly. So we have to engage through these constituency measures. And our partners who have country presence have an enormous responsibility to sort of drive and create that momentum and to ensure that the CSOs and constituencies you connect to that conversation.
Right.
Because the grant negotiations are an opportunity to demand adequate domestic resources. It's, there is a bartering of, it may not be that the Global Fund will pay for it, but you can demand that domestic commitment is made. And we've seen that be much more successful in the last round. And you can leverage that to ask for the political and technical commitment necessary. So, for example, West Central Africa. I mean, pregnant women are not getting DTG. This is outrageous and unacceptable. I mean, why are pregnant women who may transmit to their children not getting the most effective, easiest to take, cheapest, best drug out there? I mean, this is just madness. So we need we need the voices to be demanding that. Our fund portfolio managers can and do have some tough conversations, and they could sort of have these conversations to demand that sort of policy and commitment to zero preventable transmission for pregnant women and children. But we're a partnership model, so we can only kind of mirror the voices that come to us in a way. I'd like to hear men speak up. African men hold a lot of power. I do not hear them being upset about this. I hear women and young girls having to do all of the work, all of the conversations. This is everyone's business. It's not just young girls and women. We have some mechanisms of getting other additional funds in, catalytic investments, matching funds, etc. So start lobbying now. If you want to see those talk to children, you have to ask for them. The partnership model means they must be demanded. And I think sort of given constraints on the health systems and resources that we see, engaging communities, embracing innovation and demedicalizing pregnancy care to give us women the choice and agency they deserve is what we need. And I think for the high income countries, frankly, they have a duty to not get distracted. Because there's a lot of distractions at the moment, and seeing things through to the end is something we have not proved very reliable at doing in the global health community.
No, thank you, Siobhan. I think your comments, I think lead me or seg me to Florence nicely, because Florence is the director of one of the managers at JNP Plus, and civil society organizations have played an important role in shaping the local response. And clearly they could be doing much more on maternal and pediatric HIV issues. So Florence, should advocacy networks be stronger for children? Are there opportunities within your organization to do this? If you can just keep it to 1 minute, because I'd like Dee to give the last word, and then I'll pass it on to Shannon. I know we've run out of time.
I will try.
Keep it short. Yeah, thank you.
Thank you so much, Dr. Shewe and everyone for having us. Yes, I believe many more civil society advocates and networks of people living with HIV need to speak up for maternal and pediatric HIV issues. And now more than ever is the time to do this. We have had today and previously the concerns raised from not reaching mothers and interventions that could protect, vertical transmissions, not finding children who are exposed or already HIV positive in time to initiate treatment and save lives. I would, however, like to highlight the incredible efforts by civil society and networks of people living with HIV who have in the past couple of years actively engaged in pediatric HIV prevention and treatment advocacy from global to grassroots level. GNP Plus has worked alongside organizations like Y+, ICW, AfroCab, the Coalition of Children Affected by AIDS, PATA, Health Gap, faith-based organizations, and other HIV activists, particularly across the continent, to really speak strongly around prevention interventions for women and girls and availability of optimized diagnostic for children. What has been the problem is limited resources that have hampered the capacity for organizing better and sustaining civil society advocacy for maternal and children's issues. We need strong African community-led advocacy so that key policy documents like the updated WHO treatment guidelines, the just released global AIDS strategy, and the commitments from the political declaration at the HLM this week are fully translated into action at national level. So it is my hope that as governments, policymakers, implementers, and communities convene this week around the HLM, opportunities exist for making deliberate commitments to resource and capacitate community-led advocacy for maternal and pediatric and children HIV issues. Thank you.
No, thank you, Florence. And with that, I'll end it up with Dee. Dee, if you can just highlight how it's been for you as a young mother living with HIV and what your views are around the support, additional support that we need to implement within programs.
Thank you so much, Dr. Chiu. Good evening, everyone, and good morning, good afternoon. It has been a bit challenging as a mother supporting young people right now, especially now that it's COVID-19 pandemic. Because in Lesotho, we have difficulty in terms of reaching out to young people virtually, which makes it difficult for us working from home. But support-wise, I think young people or young pregnant mothers need more psychosocial support, as you'd find that some of them get diagnosed with HIV when they go for their antenatal care visits, which sometimes they don't even, their parents don't even know they're pregnant, or they don't even have supportive partners who are there with them to support them throughout the ANC and pregnancy. And now that they get the diagnosis, it becomes more difficult for them to digest and to protect their babies so that they would not transmit the HIV to them. So it's very important for us to strengthen our psychosocial support system. It's very important that the MOH help us to increase the adolescent corners, as we find that that's the only place where these young people meet and they get a chance to share their challenges as young people who are pregnant, as young people who have partners who are unsupportive, or as young people who even don't have support systems from their own families or the community at large. So it's very important that we do strengthen that. And also we want healthcare workers who are able to relate to what we go through as young people who are positive and pregnant, and for them to understand that we are young, we have so many things to do, and we now we have children that we have to protect. Like everyone's lives are in our hands. So it would be very great to have the support system from the facility, would have the support system from the community as well, and give out information on how to protect our children as we are carrying the AIDS-free generation in us, and we are responsible for that as well. So thank you very much.
Thank you, Dee. With that, I won't even try to summarize because we're way over time. I'll pass it on to Shannon to end this session for us.
Great, thanks, Chewe. A fabulous panel, very much living up to expectations. So let me briefly thank all the speakers and moderators, as well as the organizers of this session. I think we had an ambitious agenda, and I also want to thank the audience, because by my generous calculation, we've had at least a 75% retention of our peak audience, despite the fact that we're over time. So unfortunately, higher than treatment coverage for children. So we, got to catch up there. But I think it's really a signal of how seriously everyone takes this topic, and also how fabulous and informative our variety of speakers are. We've heard this year of presidents and prime ministers walking around their country with a card in their pocket that says how many people died of COVID last week, how many people got newly infected with COVID last week. I hope as we go into this year and the next year, I would like every single leader to have a card in their pocket that says how many kids living with HIV are missing in my country that don't know they're HIV positive and can't benefit from the services that would make their lives better. I would like them to have on that card how many children got unnecessarily infected with HIV last year. And I would want them to aspire to have a new card the next year that fundamentally transform those numbers. Because I think there's something about the invisibility of what we're talking about. Not being loud enough, not being visible enough, and we need help. We need the help, not of technology, not of interventions, not of science. As Linda, Gail, and others said, we know what to do. And you've heard so many practical supports today on what to do. We need this to be at the forefront of our political leaders so they can help galvanize these solutions at scale. So I'm going to wrap up with a couple of treats. We have a final video from Dr. Rochelle Walensky, the director of the U.S. Centers for Disease Control and Prevention. And then for those of you who think you have to go and stream Netflix or something else on your TV, we are going to go ahead for anyone who can stay in our lovely virtual room. And we are going to stream the first 4 videos that we missed. So the 3 that we've talked about, and then UNICEF has a wonderful video that they've put together as well. So I can tell you it will feed your soul a lot more than any other video or TV. So with that, we are going to go to the videos and just to say thank you. Thank you to everyone.
For the past hour or so, you have heard from many distinguished speakers, indeed some of whom are my former collaborators and dear friends, on the progress that has been achieved when we come together to put health equity at the forefront of our work around the globe to provide the best start in life for children living with or at risk for HIV. I'm honored to be here, figuratively, standing strongly with them to share my thoughts and those of CDC on how we will accomplish this goal. Health equity is at the core of everything we do at CDC. Health equity is when everyone has the opportunity to be as healthy as possible, including children around the globe. We recognize the systemic nature of the inequities that exist in our healthcare infrastructure. And while we all saw these structural inequities before, and certainly we in the HIV world have been working to tackle them for decades, the COVID-19 pandemic made it clear that we cannot be healthy as a nation or around the world until everyone has access to healthcare. As you all know, of the 1.8 million children living with HIV in the world, only 53% have access to treatment. These children deserve a diagnosis, treatment, and health. As has been noted, last week the world marked 40 years since the first 5 cases of what later became known as HIV/AIDS were officially reported in CDC's Morbidity and Mortality Weekly Report. Last week, the MMWR published a report that shows the substantial progress we have made in the United States in the 40 years since that first report, emphasizing that we have the tools to end the HIV epidemic: testing, treatment, and prevention options. Sadly, those tools are not universally available, and in much of the world, it is women and children who are left at greatest risk. We must close gaps, and we must ensure that those tools are equally reaching all who could benefit most. In 1993, ACTG 076 confirmed for us that we can prevent mother-to-child transmission of HIV if we can ensure all pregnant women are tested for HIV and those living with the virus are on treatment. Now, nearly 2 decades later, we have made substantial progress, but still there are approximately 150,000 children diagnosed with HIV each year. We must work to increase access to antiretroviral treatment for women living with HIV, recognizing that while we have been successful in increasing access in some parts of the world, other parts, like Western and Central Africa, continue to lag behind, with fewer than 60% of pregnant women living with HIV having access to HIV treatment. We must also look to novel, innovative tools to bring the number of new diagnoses in children to 0. HPTN 076 is a landmark study that gives me hope. Women around the world can have access to a safe and effective method of HIV prevention, one that many women found preferable to a daily pill or a vaginal ring. As we increase the number of women on PrEP, we can diminish HIV infections among women and further eliminate mother-to-child transmission of HIV. Importantly, CDC's commitment goes beyond access to treatment. There are an astounding 13.4 million children orphaned by HIV. As a key implementing agency of PEPFAR, CDC supports and facilitates intensive services for those children, improving their health and also focused on nutrition, education, social services, household economic strengthening, parental communication skills, and legal services. These children deserve so much from us. It is our job to protect them so they can focus on learning more, dreaming big, and becoming the future leaders we know they are and that we need them to be. We continue to work with ministries of health around the world to implement PEPFAR's strategic priorities and to partner with communities so that children can be safe when they grow and play in their homes, surrounded by their family and friends. This work has already touched the lives of over 1 million children and family members, including an intentional focus on girls and young women to help them complete their education and provide them with the resources they may need for HIV treatment and prevention. Today's event is a remarkable coming together of key decision makers in the interest of addressing a long-standing healthcare inequity and human rights issue for infants, children, and adolescents at risk and living with HIV. We believe children from infancy through adolescence have the right to live HIV-free and AIDS-free, and we have the duty to protect and ensure that right. Some may still think that treating children and adolescents is too difficult, too complex, too hard. I have 3 adolescents. I understand the challenge, and wow, do I understand the rewards in seeing the young adults they become. I believe that we can do hard things and that failure is simply not an option. Others may think that pediatric and adolescent HIV is not a priority given the many health concerns facing the world. I believe, as we have already seen across the globe for adults, that if we build strong pediatric and adolescent HIV programs, we will also contribute to a much-needed pediatric infrastructure that will go a long way to improving overall childhood health. We have already made tremendous progress, preventing HIV in millions of infants, screening for and treating TB in countries around the world, and bringing community-based interventions to those who need them most, improving access to education, food security, and violence prevention services. We need to leave this meeting knowing and understanding how to keep us moving forward and working to do what is necessary in each of our countries, homes, and organizations to close the gaps that remain. We need to declare what we will be accountable for and to work together to achieve it. In that, you have me and CDC as an enthusiastic partner. Thank you.
We are here today to remind the world that when it comes to HIV, children and adolescents are being left behind. World leaders are coming together at the virtual high-level meeting on AIDS to discuss our joint global action and commitments. Unfortunately, for mothers, children, and adolescents living with HIV, we have bad news to report. None of the 2020 global AIDS targets for children were achieved. And time is running out. As a global community, we must redouble efforts to get back on track to ending AIDS in children. The most recent data tells us that somewhere in the world, another child or adolescent becomes newly infected with HIV every 2 minutes. That is 880 children, adolescents every single day. In 2019, 200,000 pregnant women living with HIV did not get the services and treatment they needed to protect their babies and preserve their own health. It does not have to be this way. To prevent and treat HIV in children and adolescents, we know what many of the solutions are. We have quicker diagnostics, better drugs, and smarter service delivery than ever before. At today's meeting, let us recommit to these game changers. Let us scale them up for every child and adolescent. Let us end AIDS once and for all.
In 2019, nearly 90% of new infections among children globally were found in sub-Saharan Africa. It's unacceptable that infants and children are still dying from AIDS. While children only accounted for 5% of people living with HIV in 2019, they represented 14% of all AIDS-related deaths. Despite over 20 years of action to prevent mother-to-child transmission, every day in 2019, more than 800 children and adolescents became infected with HIV, and 310 of them died from AIDS-related causes. Only 1 in 2 children has access to life-saving treatment, and only 1 in 3 achieved viral suppression in 2019, compared to 60% of adults. Among adolescents, 5 in 6 new infections are among girls, and with high adolescent birth rates in HIV endemic communities, we're missing opportunities to create and deliver services that girls and young women need, delivered in ways that they accept. We become reliant on a business-as-usual approach when we should be innovating, advocating, and engaging communities, and now other priorities like COVID-19 demand our attention. We have lost our sense of urgency, our sense of injustice. During this high-level meeting, we have the opportunity to change this trajectory. We know that the work becomes more difficult as we get closer to our goals, but we need to zoom in on the groups being missed. While adults are nearing the 90-90-90 targets, on all accounts, adolescent girls and children are doing worse. Recognizing the pivotal role of mothers and caregivers, governments and partners need to ensure access to WHO-recommended interventions such as prompt infant diagnosis, and where possible, that point-of-care tests are used to rapidly return the result and immediately start life-saving treatment. I urge countries that have committed to introducing pediatric dolutegravir for children over 3 kilograms and 4 weeks to implement this new WHO policy as soon as possible. At the same time, we need to keep raising the bar on efforts to eliminate mother-to-child transmission of HIV. Botswana and Namibia are ready to embark on this path, and we'll continue to support them and all African countries to make it a reality. Innovative approaches are needed, coupled with renewed action from national and community leaders on pediatric HIV and AIDS. Urgent attention is also needed to address the inequities facing women, adolescents, and children, which have been exacerbated during the COVID-19 pandemic. Investments in prevention, diagnosis, and access to treatments delivered through strengthened primary healthcare services and empowered, enabled communities will help to close the persistent gaps for children and adolescents. We must travel rapidly on the last mile of elimination of mother-to-child transmission of HIV and accelerate the pace to meet the new global targets of 0 new HIV infections. Across the 3 levels of WHO, we stand ready to do our part.
We are failing children with the current HIV response. 2020 will be remembered as a year in which we failed to reach the global AIDS targets for children, adolescents, and young mothers, in which the COVID-19 pandemic exposed inequalities and extreme vulnerabilities facing populations living with and at risk of HIV. 90% of all children living with HIV globally are in Africa, and only half of children living with HIV are receiving the life-saving treatments they need, compared to 2 in 3 adults. Although children accounted for 5% of people living with HIV in 2019, they represented 14% of all AIDS-related deaths. This means that 850,000 children living with HIV are at risk, a matter of grave consequences. Despite these challenges, many countries showed extraordinary leadership and delivered progress. We saw an increasing number of countries join the list of those with over 80% treatment coverage for pregnant women, putting them on the pathway to elimination of vertical transmission. We also saw renewed commitment by countries to strengthen and integrate comprehensive HIV response into national health systems, as did 18 countries in West and Central Africa through the Dakar Call to Action. UNAIDS, UNICEF, WHO and their partners, including EGPAF, ICAP and M2M, call on all governments to continue to show their strong leadership and rewrite a bold political declaration with children, adolescents and young mothers at the center. Let us end AIDS by ending all inequalities in HIV prevention and treatment. Together, let us commit to a world with no children and adolescents with AIDS.
Goodbye. Good evening. Good day. See you all tomorrow.